Who remembers Family Feud? Anyone watch reruns late at night? Well, the way Family Feud worked was that they would survey people on the street and put the most common answers up on the big board for people to guess. So that's what we are going to do right now. We have the top 11 answers on the board for when I ask residents or students, what drugs cover MRSA? Take a minute to make your own list and then we can compare. So if you said vancomycin, ding, 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 that's the number one answer on the board. Vancomycin is often the first antibiotic we think of when we think of MRSA. It works for all kinds of infections: bacteremia, endocarditis, pneumonia, skin and soft tissue infections, and others. Now, naming the antibiotic is one thing, but let's take this one step further. Can you think of the toxicities and monitoring that has to happen with vancomycin? For those of you thinking nephrotoxic, you are right. Vanc requires regularly monitoring levels to prevent damage to the kidneys. For serious infections, we want the level to be 15 to 20 before we give the next dose. What's another toxicity? Don't forget about red man syndrome, where patients turn red during the infusion. Some people think this is an allergy, but you know better. This is an infusion-related reaction, and you can just slow down the infusion and keep going. Speaking of keeping going, what do you think the next MRSA drug people think of is? Number 2 answer on the board is linezolid. Everyone always thinks of linezolid, so why do we love it so much? Well, there's a few reasons. It covers MRSA and it's equivalent both IV and by mouth, so if you want to send someone home on it, it's a great choice. What's another reason that we like it? Well, unlike vancomycin, it doesn't require levels. Dosing is straightforward. You don't need any specific toxicity monitoring either unless you're giving it long term. So what are long-term effects? You should think of peripheral neuropathy as well as thrombocytopenia. So why don't we use linezolid for everyone? Well, just like antibiotics, if you overuse it, you can lose it. So we need to save it and use it when appropriate. It's also not the most appropriate drug data-wise at the moment for bacteremias. It also plays an important role in treating other gram-positives coming up later. So we have the top 2 answers on the board. What do you think number 3 is the most remembered MRSA drug? Ding, 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 clindamycin. So internists and pediatricians love clindamycin since it's an IV or oral agent that covers MRSA and gets excellent levels in skin and soft tissues. But is it most ID docs' first choice? Depends a lot on where you live. For me, it's not empirically because we are seeing growing resistance to clindamycin and many community isolates are resistant. However, once you have sensitivities, it's a great choice because it's fairly narrow. It covers gram-positives, anaerobes, but no gram-negatives. It's pretty easy to tolerate. Yes, it can cause GI upset, and yes, it can cause C. diff, but not necessarily much more than any other antibiotics. It has a bit of a bad rap. Other pluses: no monitoring required. So by now it's probably getting harder. What do you think the 4th drug on the board is? Ding, 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 ding! It is Bactrim, otherwise known as trimethoprim sulfamethoxazole. I know I am supposed to avoid brand names, but trimethoprim sulfamethoxazole is quite the mouthful. It is available both IV or oral, and it's well absorbed, but dosing needs to be weight-based. This is another drug that works for MRSA and is great for skin and soft tissue infections, but also offers some broader coverage, including gram-negatives like E. coli seen in UTIs, of course. It does not require any monitoring of drug levels, but is it perfect? Well, not quite. If you have G6P deficiency, you can get a hemolytic anemia, and you have to watch those kidneys as well. Bactrim inhibits sodium channels, slowing down potassium excretion, so you can get an elevation in potassium. And then what about creatinine? Well, Bactrim can cause an interstitial nephritis in and of itself, but most of the time you see a creatinine rise, or at least a small one, it's a big fake out because what this drug does is inhibit creatinine secretion. So your creatinine goes up a teeny bit, but your GFR is actually just fine. Lastly, of course, if you have a sulfa allergy, you cannot take Bactrim. Survey said this one is actually in my personal top 3 and begins with a D. That's right, daptomycin. Daptomycin is a great drug for gram-positives, including MRSA, but it's IV only and doesn't offer any gram-negative coverage. It's actually FDA approved for endovascular infections, so worth considering for your patients with endocarditis, and it doesn't require levels like vancomycin. Is there a downside? Well, you do have to check the CPK when you start and then weekly because it has been associated with rhabdomyolysis. The next drug on our board is doxycycline, and it is a favorite drug of ID docs. Doxycycline and minocycline too are great. They cover gram positives, including MRSA, several gram negatives, atypicals, tick-borne infections, and even some sexually transmitted infections like syphilis and chlamydia. Of course, not if you're a pregnant woman, then you're not going to give doxy for syphilis. What are the downsides? Well, if you get Lyme disease in the summer, photosensitivity can be quite the problem and you can get really bad sunburns. Not too common, but it is a known cause of pill esophagitis. And maybe the last point to make is that, God, what about those darn kids? Well, we used to say it was contraindicated in pediatrics for kids under 8, but now we know that was probably a remnant from when we used actual tetracycline. Now the Red Book, which is basically the pediatric ID manual, doxy is okay for kids of all ages under 21. Now on to the right side of the board. To keep this moving, let me give you a hint. I like to think of Florida orange juice. Too vague? Well, if you were thinking, survey said, rifampin, you were right. Rifampin is another drug that covers staph in addition to its work for TB. It's the RIPE of RIPE therapy for TB and non-tuberculous mycobacteria. An important point is that we almost never use it alone. 1 point mutation and it's gone. So generally, we use it in combination with other antibiotics, especially for device-related infections, to help out another antibiotic once the bacterial load is down. For this one, you have to warn patients about their orange-colored fluids. It literally makes everything orange. It's not harmful, but it will definitely freak your patient out. You also have to monitor their liver enzyme to make sure you're not having any toxicity. The next drug on our board is a great drug but a toughie. You need a hint? Well, they call it a 5th generation cephalosporin. Ding ding ding! That's right, it's ceftaroline. Just to clean up a myth, that 5th generation cephalosporin stuff is all marketing. Normally we think that as you go up the generations you get more gram negative and less gram positive coverage, more or less. But ceftaroline is just ceftriaxone plus MRSA coverage. So don't fall for the media hype and just think of it as a 3rd generation with MRSA coverage. As you can imagine, we only use this drug when we really need to and have a refractory infection. Survey said this next one is really tough. It is tigecycline. Tige what? This is in a newer class of antibiotics called glycylcycline antibiotics. It was really promising for a while for very resistant gram-positive infections, including MRSA or Enterococcus, and even some gram-negatives. But then studies showed that patients who got it had a higher mortality. Whether or not this is just because they were so sick or caused by the drug, I don't really know. So it turns out this drug is distributed widely. It is highly protein bound though, so it's not useful for bloodstream infections, but can be helpful for highly resistant intra-abdominal infections or even maybe UTIs if other drugs can't be used. So what is drug number 10? I'm just going to tell you because it's so hard. Um, this drug, or these two drugs, are called dalbavancin and telavancin. They are synthetic derivatives of vancomycin. They're lipoglycopeptides. The cool thing about dalbavancin is that it has a really long half-life, so you only have to give it once a week, which is amazing. Though you still have to watch the kidneys, so you don't want to give it to someone who has questionable or changing renal function. So it has some uses potentially for people you want to discharge without an IV, and it can cover their last week of therapy. So for this last drug on the board, maybe 1 in 100 people would get it, is a true blast from the past. It is called quinaprisin dalfaprisin, otherwise known as Sinersid. It can cause vascular inflammation at the infusion site, a real vasculitis, other infusion reactions like chills and horrible myalgias. I haven't given it in over 10 years, and I hope you never have to. And that's it. Now you have the entire armamentarium for MRSA. Commit this to memory for the next infection you see. Are you ready for the next set of rounds? Drugs that cover... To be continued.